Hi, I'm Ali Buchanan, Clinical Lead Occupational Therapist.
Hi, I'm Kat Brown. I'm the Specialist Occupational Therapist in this OT caregiving pathway.
Yeah, and that's what we're here today to talk to you about. So a little plan for what we're going to cover. First tech problem, there we go.
Okay, so our plan for today is to kind of introduce the East Lothian Rehabilitation Service. What was the opportunity? How did we set up the pathway? What was the vision? And what occupational therapy can provide? We're also going to touch on where we fit within the East Lothian Health and Social Care Partnership, what have been our outcomes, and what have been our challenges and opportunities, and what the next steps in future planning are.
So the East Lothian Rehabilitation Service covers the whole of East Lothian. You can see here on our map the kind of the geography of this region. We are an integrated team. We include NHS and East Lothian Council staff and a variety of professions, so occupational therapists, physiotherapists. We have assistant practitioners, exercise specialists, telecare technicians, driver support, admin support, and that's who makes up our rehab service. We cover a variety of pathways, so we see people in the inpatient setting here at the East Lothian Community Hospital, within the community, and we cover our scheduled and unscheduled care pathways of discharge to assess, prevention of admission and so on, and also outpatient services. Carers are traditionally always incorporated into our occupational therapy and physio assessment and interventions for our therapists, but they're not the service user, and that's really where this pathway differs to what we've done before. So the opportunity we had was posed a couple of years ago now. We have a Carer Strategic Board within our Health and Social Care Partnership, and they invited people across the partnership to submit bids. My service manager came to me and said, think differently, you know, what can we do? That the aim here is to do something differently that's been done before with carers. Opportunistically, I had just started completing my postgraduate masters in advancing practice of occupational therapy, and I was completing an occupational science module. That's all the kind of theory underpinning the power of occupation, the kind of the doing, the things that we do all the time. And this was really pivotal in shaping my thinking about what we could do differently, about really putting the carer as the service user, what we would term in occupational therapy as the occupational being, the real kind of centre of what we're doing. And a bit of brief literature searching really helped me identify that there really wasn't something similar around the place. I was looking kind of globally at different things and couldn't find something similar. So I was trying to think out the box and sort of synthesising, as I say, all that kind of theory into a presentation I then delivered to the board. I have to say I was kind of guesstimating to a degree of what I felt we needed and what I thought we could do, because there wasn't something that already existed. It wasn't a kind of case of pulling this off the shelf from someone down the road. This was doing something really from scratch. And so what we put forward was for a whole-time equivalent occupational therapist, a whole-time equivalent assistant practitioner, and a part-time administrative support within the pathway. The aim I was trying to get across is about predicting impact and deliverables of really an early intervention model with people who find themselves in a caregiving role. So this kind of slide shows you a bit about the setup and the process that we went through. And starting at step one, I mentioned there about the bids that we submitted and the presentation I did to the board, and we were successful, which was amazing. I've never done anything like it quite before. It was during COVID, so it was on Teams and things, and it's a bit scary, but we got there. So the next step of having been allocated that money was then to undertake the recruitment process, and then trying to hang a bit more detail around that vision. That then meant inducting staff, which was fantastic, and then the process of really scoping the pathway. So looking across the partnership and across Lothian as a whole, what teams exist, where can we pick up some of the learning, and what do we need to be doing to interface with them. There was then step three around that real kind of a process of designing our internal processes. What would that look like? So how are we going to accept referrals? How are referrals going to come through? What are our criteria going to be? How are we going to document? All of these kind of real nitty-gritty things around what we were going to do. We then conducted presentations in order to roll out the pathway to different groups of staff, starting within our rehab service and all the different pathways I've mentioned, to then going out with that to other services across the partnership, including our colleagues in mental health and others as well. The reporting structure was quite key for us. So this is around monthly reporting. We're using highlight reports where we're pulling data on what activity we've been doing, also looking at service user evaluation, and we'll come to this a little bit later too. But that's been really, really key in reporting back to the strategic board as well as our own service manager too, about kind of what we've been up to and where there have been challenges, what we need to work through to overcome those. Really thinking about kind of PDSA models, really kind of underpinning that. And then that continual process as well of reviewing and reflecting through the supervision that Kat and I have. So making sure that we're really analysing everyone that we're seeing from a service user perspective. Again, what's working well, what's not so well, we didn't expect this, so what are we going to do about that? And constantly evaluating what we're doing. Our kind of beyond bit we'll come to again a bit later is around looking at further bids for funding to expand what we're doing. Because I probably should say that whilst we had that funding for those 3 members of staff, we weren't successful in recruiting a band 4 and the funding was pulled. So the service currently operates with the whole-time equivalent band 6, which is Kat, and our admin support, which also got reduced a little bit, unfortunately, so it's less. I think at this point I also just want to highlight that situating the occupational therapy resource for this pathway in the rehab service has been absolutely fundamentally important. And it's not that we've plucked an occupational therapist and put them in a different service or somewhere separate, and that's meant that we've had all the appropriate levels of governance, of escalation, of supervision, of training, of all the things that our rehab service offers, to enable this pathway to be as sustainable as it possibly can.
So for us, we were quite clear about what we wanted the vision to be. So we've created this about it providing an occupational therapy pathway which allows proactive intervention at the earliest point by enabling carers to live and flourish in everyday life, whilst managing their caring responsibilities in a sustainable way. As Ali had mentioned, all professionals see carers, but what this pathway allowed us to do was to see the carer as our client, as our patient. They became, the centre of what we were doing. And that allowed us to kind of build a therapeutic relationship, and not just purely tackling the challenges in caregiving, but also just about their health and well-being, their quality of life, things that would make them more resilient, healthy, and achieve a balance in their daily occupations, which was really key and fundamental what we were trying to achieve, that they were seeing. So, occupational therapy helps people of all ages overcome challenges in completing everyday tasks or activities, and those are what we refer to as occupations, everything you need to do, have to do, and want to do. Occupational therapists, we see beyond diagnoses and limitations, and we're very, to the hopes and aspirations, very strengths-based focused. We look at relationships between the activities an individual does every day and the challenges and the environment and how that impacts you. So our Royal College of Occupational Therapists this year has stated that we create a plan of goals and adjustments targeted at achieving a specific set of activities. The plan is practical, realistic and personal to you as an individual to help you achieve breakthroughs you need to elevate your everyday life. And that's really quite key about why it's occupational therapy and what we can do, because we're seeing them as an individual, not just as a carer, but their strengths and challenges and what they bring to the table and their, life moving forward. So, as Ali and I have mentioned, we focused on the unpaid caregiver as an occupational being. In order to, that helped us frame what we were looking to do, and it was very person-centred in the approach of assessing their occupational performance. So, proactive interventions are what we look to kind of use a strengths-based approach, improve resilience, improve occupational balance, and also overcome occupational deprivation. So it's about looking at not just the individual, but everything that they're tapping into in a day, in a week, and how that impacts them. And I suppose it was about giving them permission to engage in occupations that were meaningful and valuable to them. So it's quite key. And as an occupational therapist, therapeutic use of self in this role has been a privilege and allows me to keep expanding as an OT. So in order to kind of ensure that we were, that overarching occupation, we are using the Canadian Occupational Performance Measure. And what that does, it's an outcome measure. And we, when I meet with an unpaid caregiver, we sit down and we identify challenges. And what they do is they rate it. It's their scoring. So they rate the importance, and then they rate about the performance of the occupation and their satisfaction, and that's the starting point. And the self-rating scale is really important, because when we come back to it at the end of our therapeutic intervention, they again self-rate it, and in doing so the score is very empowering to them, because they can see what they've achieved. So part of that, of what we were doing is, I look at assessing some of their activities, using that activity analysis, any task modification, provision of equipment or suggestions for equipment, done a lot of kind of graded practice and backward chaining, lots of education and teaching and advocacy, and really kind of core OT when working with the individual.
So to give you an idea of what this process means kind of on a day-to-day basis, this slide hopefully just takes you through that. So when a carer meets the criteria for the pathway, they're provided with an information leaflet by the person that's been working with them to give them an idea about what the expectations are for the pathway, what will happen and what we're aiming to achieve. And then they have that option to really discuss the referral with us from the professional. So if there's perhaps a dementia link worker that's making the referral, or a physiotherapist, they can get in touch with us, they can have that conversation. I've got, somebody I'm working with, they've got a husband or wife that I'm concerned about, and these are the issues around carer stress, or they're really overloaded in their role. Is this someone that you could work with? So we can have a really good informal conversation with them first before accepting that referral. The referral itself, we've tried to keep as easy as possible, that process, so it's a side of A4 with the least amount of boxes as possible of information that are key, so the person's name and demographics and kind, that kind of thing. Most importantly, that they've consented to working with us, that there are clear kind of goals in which they want to be achieving. There's usually a bit of a nod to the person that they're caring for to give us a bit of a context, but the referral form is very much about that person as the carer and them as the own, as we mentioned, occupational being. They send that referral through to us via email. Our admin staff enable then to pop that straight onto the track waiting list, which is our electronic system that we use in health here. The admin team create a pack for us, which is great, which has got that printed off referral. It has the outcome measures that Kat's mentioned, the COPM, and there's other screening tools that we can use if appropriate as well for people, and also input the information into a database that we hold, which again I mentioned about reporting, and our database has been really pivotal in being able to pull off information around numbers of people we've seen, the kinds of interventions and impacts we've been having, which has been really key for reporting back to the strategic board. We then, as clinicians, triage the referral, so looking at identifying kind of how urgent it is for us to be getting involved, and we've got criteria and response times for that. Any additional information we feel we might need to seek at that stage, so perhaps there have been a couple of people where we felt not really kind of getting a full picture of this, we need to go back and just speak to the referrer and gain a little bit more before we can accept it. And then always communicating with the referrer, so Kat's great at going back to people and saying, yep, we've got this person on the waiting list, this is kind of the late waiting time at the moment, this is what we're aiming to do, often suggesting them signposting to the Carers of East Lothian, our third sector organisation in East Lothian, so that there is kind of initial contact if they haven't had that already, a nod to the fact that there might be a few weeks until we can get involved. And then occupational therapy commences. So that's our process. Where do we fit in terms of the partnership? Well, you see the caregiver being the absolute centre, and the hexagons in blue are kind of the key services across East Lothian specifically for people in a caregiving role. So there's the Carer Strategic Board that I mentioned, which has the kind of strategic oversight and commission different partners to provide services. The key ones interfacing for our service around the Carers of East Lothian that I've mentioned, the third sector organisation, who undertake carer support plans, who can be that first port of contact in terms of support and signposting and having greater frequency of contact with people. There's also a community care worker based in the social work department with a specific role for carers. She reviews those carer support plans that are coming through from the Carers of East Lothian, looks at time for me grants and other things as well, so a helpful person for us to interface with. And then you've got the OT care pathway, which is ourselves at the bottom, and again interfacing with all of these. The areas in orange are the other kind of primary agencies across East Lothian that we work with. So again, our therapy colleagues, whether it's speech and language therapy, whether it's physio, those in mental health, clinical nurse specialists that cover the whole of East Lothian and Lothian as a whole. There's our rehab service, all the primary care team from GPs, district nurses and others, dietetics, third sector, so Volunteer Centre East Lothian, who have been really pivotal in again identifying people and referring them into us, and others like Lukey House, who offer respite to people with neurological conditions, and dementia link workers. So a real kind of gambit, and what we're really aiming to do is be a bit of a bridge for some of the communication from all these different people who are involved by putting the carer at the centre.
And given that we're talking about including carers in the discharge planning, part of this was really important, and again highlights why my placement in the Health and Social Care Partnership is key. One of the examples recently, I supported an unpaid carer whose wife was here in the inpatient team. They were getting discharged. There was lots of communications, advocating for the unpaid carer, reassuring them. All of these stakeholders, including carers of East Lothian, were all pivotal, but it was about that I was able to link with my colleagues in inpatient, say, oh, I'm working with so-and-so's husband. That communication and those connections were kept open, which reassured the unpaid caregiver. And also, when he did have conversations, he was aware that the ripple from what we had tried to do had obviously started to happen. So it was all about that placement and keeping them involved.
So some emerging data for you to get a feel for what we've done over the course of the time that we've been working. So in our first year, there were 94 referrals that we received. And it was a real, if you looked at it in a graph, a real kind of like small burner at the beginning. And then the more times that we were presenting and educating people about what we were doing, the numbers were increasing, which is terrific. So the pathway started in about October 2022, sorry about that, and Cat came into post in that December, and then started taking referrals from a full-time basis really from kind of January, February time. So 130 referrals to date. We currently have a big waiting list, which is a real kind of testimony, I think, to the volume of people that have been identified by our colleagues that are needing this service, and it's sitting at around 31 weeks at the moment. Our active caseload for Cat as a member of staff sits at around 33 to 35, and that incorporates people new that she's taken off the waiting list, those that she's actively working with, and those that are probably approaching discharge too. So on average about 33 to 35 people, and that translates to around 60 interventions a month when we've used our kind of boxed reports pulling from track. Some information just around those that have been referred, just under half have been classified as urgent, and our criteria really highlights those that haven't had kind of input before, that don't have huge amounts of support structures around them, and that are really needing that input as quickly as possible to prevent the situation from deteriorating. So again, really flagging where people are in their caregiving journey. Our ultimate aim would be to see them at even earlier point that they're not at that crisis. So that's work for us to do if we gain capacity. Another bit of outcome there just for you in terms of, we have service user feedback forms that we give to everyone across the whole rehab service when they're discharged, and from that 87% of people have felt really very satisfied, which is a great outcome for us. This is data that translates the COPN that Kat was mentioning, that self-rating and self-scoring scale, which is conducted at the beginning at the end of intervention. The graph on the left is around the person's rating of how they feel they perform. That's complete those chosen activities. And the graph on the right is their satisfaction in doing so. The bars in orange show their self-rating at the beginning, before they started working with Cat, and the green is after their intervention of occupational therapy. So you can see consistently the huge change in that person's self-perception of the difference and the improvement that they've made, both in how they perform something and how satisfied they are, which is hugely powerful.
It is, and it's such rich data, not just for obviously our service, but for the individual we're working with, because like I said, I don't show them the scores that they gave at the start, and these scores that they gave at the end of the journey are true to their interpretation, so really boosting for them.
So I mentioned the feedback forms, and there's some free text at the bottom after they've kind of looked at what could have gone better, what's gone well, and some of these have been lovely. So these are from service users themselves that really reflect their lived experience about the occupational therapist being helpful, understanding, but being on that path to recovery, I think has been really powerful to hear from people. Has given good advice, has had a real impact on thinking that's kind of exceeded their expectations, that you've listened And I think that's, again, really pivotal for people in a caregiving role, that they've been listened to and really validated, that you've been constructive. And I think all those different words have been hugely powerful to hear the perception from people. Whilst Kat might be a little bit embarrassed about me reading this out, we have focused on one feedback that came back from somebody, which I think has really summarised some of the ways in which the occupational therapy input has affected them. So I'm just going to read this one out. She gave me achievable goals and much needed advice on how to set boundaries. Reassurance that the confusion, dilemmas, distress, guilt and hopelessness that I felt was real, valid and understandable, and I didn't have to continue to just accept things as they were. She gave me suggestions and techniques on how to reframe situations. Now I have a few valuable and useful tools in my toolbox. When I'm starting to spiral and face a challenge, I do have a voice in my head saying wise words. This is helping me in my process to be the best I can be and to try and ditch all the thoughts that have hitherto filled my head and been a blocker to me living my best life. So hopefully that gives you a sense of, quite powerfully, where that caregiver was from a mental health perspective and how they were dealing with things, but how the suggestions and techniques that Kat's given in terms of giving them that toolbox have been really impactful for them.
A key part of what we're doing as well is our collaborations. It's that interfacing with professionals, with our third sector colleagues. It's all about connections. And I suppose part of what I'm doing has also had a benefit in that the professionals working with the cared for have been able to see things in a different light. And some of these quotes from OT, speech and language colleagues, carers of East Lothian support worker, highlight where the understanding of where our role as occupational therapists fits and supports and actually builds on what they're already doing. I had an OT colleague come and sit with me when I met with an unpaid caregiver, and she was supporting the cared for, and she came away from that, sent an email to Ali, she had seen the caregiver in a different light. She'd actually been able to see them as an individual, and it aided what she was trying to do. So I think these are really, really rich, and hopefully you've had a chance to kind of take them in. So we can't always, go without acknowledging the challenges, and I suppose that's part of any transformational change that we're all trying to do. Thankfully, Ali has created time, but leadership capacity for clinical supervision, escalation and service development wasn't part of our initial, bid, but actually has been fundamental to me, because I've needed to have that clinical supervision, that reflexivity and that mentorship in the role that I'm doing, because it is new and there isn't anything like it. Sustainability of current staff, if I'm on holiday or off sick, there is just me, myself. Succession planning, obviously my skill set has really slotted well with what we were trying to do, and I have worked across the lifespan and have brought that with me, but it's also about the sustainability of the pathway, and we really do want to try and go to that early intervention. One of the other challenges that we continue to face is the limited understanding of occupational therapy, its diverseness, its unique perspective of individuals, and actually where it can be used in a very, proactive and supportive way. And, we're hoping that in doing this, we can shift that perception. Sometimes reciprocal communication with other services has been a barrier, but I think we just keep knocking on the doors, sending the emails, having the conversations. Data sharing and information governance with our third sector partners has been a huge barrier with our NHS secure grids, and again, OT superpower is problem solving and thinking outside the box. So we've created alternatives, but it would be much easier if we could have a direct communication. And I suppose we need more time for that further data gathering and that service development, and trying to widen what we're doing and raise the profile.
So as Kat said, whilst there's been lots of challenges, there's been huge opportunity, and I guess the biggest one is about raising the profile of people in a caregiving role. I think demonstrating that occupations of caregiving, which can often be seen and viewed as very negative, actually are hugely positive for people, and they really value being able to be a caregiver, whether it's from marriage vows, whether it's the privilege of caring for somebody they love, and actually being able to help them reframe the positives around that, both for themselves and the person they're caring for, has been amazing. And again, all those conversations, then we're just raising that profile about care, the role of caregivers in all parts of our service pathways. That's led to development opportunities kind of across the different pathways within our rehab service and across the partnership, and also from a Pan-Lothian perspective. We sit on the neuro network that we have, which interfaces with some of our Pan-Lothian colleagues and services. That's been really, really interesting. The opportunities for joint assessments and education, as Kat mentioned, that means actually for us to do an occupational therapy assessment alongside a speech and language therapist, or an occupational therapist who's seeing the service user, and then having these two different perspectives coming together to really problem solve and ultimately improve the situation for someone has been great. The skill set of occupational therapists, as Kat said, is diverse and very well suited to working with people in a caregiving role because of its breadth and depth, and the way it's looking at the activities that are important to that person at any one time, particularly when we're thinking about role overload, which is the occupational balance Kat mentioned before, which is hugely prevalent obviously for caregivers. So being able to address that has been a real opportunity. Linking with the strategic board, I would say the Carers Coalition and Health Improvement Scotland has raised the profile hugely for us and been really, really powerful in the conversations with them been having more locally to have these kind of big organisations behind us. Being able to explore and enhance the narrative for our caregivers has been, again, so interesting and a real privilege. And we both continue to do our masters, so something that we're both interested in pursuing and investigating and understanding a lot more too. And so with that comes more robust audit and research. So in terms of our next steps, we're currently working with the Carers of East Lothian to develop some education sessions and courses to look at really how we can bring the Carers of East Lothian and ourselves together in delivering more information to caregivers, and using joint case studies where Kat has been working with someone in Carers of East Lothian to really demonstrate that interface of the two different roles, which hopefully will help others within the Carers of East Lothian to really understand. Some workers have really grasped this really well and the difference in kind of the profession, and others have struggled. So actually doing a collaborative case study, we're hoping will really help them. We've mentioned about focusing on early intervention. It's absolutely why we came into doing this, and it remains our focus if we can get some capacity to do it and maybe do things in a different way. And we're going to look at using some of time looking at the inpatient setting and how we can look at maybe doing some information groups with caregivers whilst their loved one is in the inpatient setting on the ward. So that's an area we're going to kind of tackle. The pursuit of further funding is something that we need to continue to do in order to really address the capacity that we mentioned in terms of our waiting lists and the volume that are coming through. And I guess through some of that is being able to succession plan, as Kat mentioned. We've got Band 5s rotating across the service. And our aspiration, if we did have further funding, would be that we'd have a Band 5 in this, so really kind of gain skills and knowledge that they can take them through the other areas of the rotation as well, which would be terrific. And then focus groups, as I mentioned, partly from our master's perspective, but to really understand the lived experience of our caregivers from an occupational therapy perspective is ultimately where we would like to get to as well. So that's the end of our presentation today.
And thank you for taking the time to watch it and kind of seeing the opportunities for occupational therapy and also for the spotlight on unpaid caregivers.
Thank you for your time.
Thank you.